And I'll turn this back to Dr. Jacobson then.
Thank you, Dr. Kenny. I'll remind the viewers that you're able to send questions to the panels. If you click on the button, ask a question, please do that as soon as you can. We have now heard about the anatomy of impingement. We heard about the symptoms. And Dr. Simenstad, what can be done about that if you have impingement?
Well, thank you, Dr. Jacobson. There's several things that can be done about it, and it depends, as we said before, on where you are in the continuum of the process. If you're early in the process or it's been discovered early before damage has occurred to your hip joint and significant arthritis has occurred, there's a certain set of options, which we call the nonarthroplasty options, which don't include a replacement surgery. Then there's another set of options, which are the arthroplasty options if the symptoms have gone on and the progression of the process has gone on to develop severe arthritis. And so we're going to talk about both of those cases. First of all, the non-arthroplasty options. There's several of those options, but the one that is probably considered the quote-unquote gold standard, or the one that's been around the longest, is the one called an open dislocation with a trochanteric flip osteotomy. And this was discovered or described by Dr. Gans in Switzerland many years ago, about 15 years ago. And he discovered that you could actually dislocate the hip and expose the entire hip joint by doing a special approach which would preserve the blood supply to the head. He published these reports, and then actually others here in the United States subsequently published their reports, which had very good results with the surgery. And the surgical exposure does nearly expose the entire hip joint and allows for treatment of almost all non-arthroplasty options. And it can be done relatively easily through this approach once it's done. It also can be converted to a hip resurfacing if need be during the procedure, if one encounters more arthritic change than one had suspected on X-ray or MRI. But lastly, it preserves the blood supply to the head, so that this is extremely important when exposing the hip joint, because this avoids problems such as avascular necrosis of the head, which can result in arthritis itself. Now, some other options that are evolving are limited incision or small incision surgery and arthroscopy of the hip. The problem is that they are evolving and that they are still relatively difficult to perform and visualize and treat all problems related to impingement. And actually, there's few published reports on the outcomes of these procedures. And lastly, they can't intraoperatively be converted to resurfacing if significant arthritis is encountered during surgery. Now, another non-arthroplasty option, which is only really applicable in very rare cases of overcoverage, is pelvic osteotomy. But mostly the options are related to the first option that I described. We'll also talk about total hip resurfacing. This is for the patients with impingement that have essentially gone on to develop such severe arthritis, or they can be other patients with that result in arthritis from other causes. But it essentially means capping the head, and by doing it through the impingement approach or the trochanteric flip approach, one can preserve the blood supply to the head if done through this approach. And also, one of the advantages to total hip resurfacing over total hip replacement is it restores more normal hip mechanics for most patients. And it allows the young patient to return to unlimited activities, probably at a higher level than they could with a total hip replacement. The two procedures we'll show today, as I stated before, are the open dislocation through a trochanteric flip osteotomy. As I stated before, this does preserve the blood supply to the head by the nature of the approach. And to do so, it means detaching the muscles of the hip temporarily by cutting the bone where the muscles actually attach to the hip. And later that bone is reattached with screw fixation and is allowed to heal bone to bone so that the patient has normal muscle function after it's completely healed. Now to describe this approach a little bit better, I'm going to show you some drawings from the literature, which basically show where the osteotomy is done. And I'm going to have Dr. Kenny point to this dotted red line, which is where the osteotomy is done, right below the attachment of both the muscle coming from below and above to the hip. And you can see the artery going into the neck of the femur and going to the trochanter, and the head below that. So our goal is to actually just slightly detach those muscles by removing that 15 millimeters of bone intraoperatively. As you can see, here's the saw cut performed, and diagrammatically, and then finally that muscle is then flipped, quote unquote, with the bony attachment to the front of the hip socket, and actually exposing the capsule underneath it, as will be pointed out by Dr. Kenny, and then we can incise the capsule and dislocate the hip and do the operation that we need to do. Total hip resurfacing, just as a summary, was done probably about 30 years ago or longer in the United States, but fell out of favor because of the implants used. At that time they were plastic on metal implants and had significant wear associated with them. They were redesigned and introduced in England about 15 years ago with metal on metal bearings, and they've become popular in the European arena, but recently in the last 3 to 4 years have been done here in the United States more frequently. And resurfacing can be done through a standard hip incision, although this can compromise the blood supply to the head in the process, or through the trochanteric flip, as I'll describe. I feel that the trochanteric flip has advantages. One is it's easier for me to position the implants, I believe, and exposure is quite good. And then also it preserves the blood supply to the head, which is what we're actually placing the cap on, so I believe that's important. The first case we're going to show, though, is just an impingement case that's caught relatively early in the phase of impingement in a 30-year-old who did not have a labral tear, but had significant pain with walking, as well as pain extending back at least about 5 years like this, and probably even back as far as her teenage years, if carefully questioned. The groin pain was completely relieved with an injection, and she has some mild hip dysplasia on her x-ray. And I'm going to have Dr. Kenny actually illustrate those finer points on her x-ray now.
Here you can see we have 2 x-rays in this patient. This is a frontal view for the whole pelvis, and then this is the groin lateral view that Dr. Simenstad had talked about, where we're looking up at the hip joint to show the front of that head-neck junction. And you can see on the frontal view, the head is nice and round and the neck looks fairly nicely contoured, and there's not a real dramatic abnormality with the socket portion of the hip joint. But as we move to that groin lateral view, you can see that as compared to the back of the head-neck junction, which is nicely scooped out and contoured, there's a fairly prominent but shallow bony bump here in the front, and that's the cam lesion that's resulting in the patient's symptoms.